Hi, here I am back to present another extraordinary speaker. This time I'm proud to present my friend from Poland, Dr. Maciej Żerał. Maciej got his degree from Budapest University and his specialization in operative dentistry. He then started as a faculty in the university in Krakow, where he defended his PhD and also where he finished his specialization in endodontics. Dr. Żerał is the author of a book called Endoprosthodontics Guidelines for Clinical Practice, published by Quintessence Publishing, and it is published in 3 languages, which is a book I truly recommend. Besides being a member of many scientific groups, Maciej is also an honorary member of Style Italiano Scientific Group and has published a large number of papers in Polish and international journals. Dr. Żerał runs a private practice and an advanced educational center in Krakow in Poland since 2003. We are looking forward to hear his presentation about the reconstruction of endodontically treated anterior teeth. Let's watch Dr. Maciej Żerał. See you soon.
Hello, dear friends. Welcome to the next lecture of Aesthetic Masters. Actually, I'm very ashamed, but also honored to be Aesthetic Master, because of course I'm not, but I'm trying to be the best I can, of course, in reconstruction of endo-treated teeth. And I'm very happy that I was invited to lecture about this topic here on the Congress. And it's a great idea. Congratulations to my Portuguese colleagues that they invited lecturers from all over the world, 25 countries. It's amazing idea to share the knowledge among the continents and countries. And really, my sincerely congratulations. So the topic of my lecture is reconstructions of endo-treated anterior teeth. First, I'm endodontist, and second, I deal with the restorative dentistry since many years, and I dedicated my PhD and my clinical practice to endo-treated teeth and their reconstructions. So I will try to share with you evidence-based and today's clinical knowledge about this topic. First, I would like to share with you my thanks to the mentors that I have since many years. I have a lot of mentors among my colleagues, but I would like to mention 3 of them today. One is my dear friend Marco Nicastro from Rome. He is the prosthodontist, and he's a very important person in my life because he taught me most of the technical clinical skills that today I have and use in my office. And I'm happy to be his friend till today, and he's mentoring me till today. Second, in the middle, you have a Professor Kropinski, the professor from Krakow University that was my boss since many years at the university when I was teaching the students. And till today, we are running the courses, educational courses here in our educational course center in Krakow, where I'm lecturing for you today. And the third person, Walter Devoto, the founder of Style Italiano, a person who is looking very much forward and giving me inspiration and ideas for new things and new ideas in dentistry. This is very important always to have a new motivation. And thanks to new motivation, I was able to write a book, Endoprosthodontics, which was published in 5 languages till now, in Polish, Russian, English, French, and Croatian. And also thanks to my dear co-author colleagues that were writing together with me. The aims of the lectures, I will try to go as we go with the letters of the alphabet. A is the aesthetics, and I will try to speak about understanding of the aesthetic problems associated with endo-treated anteriors. B, like bleaching. Bleaching is very important today, and it's very important not only for the vital teeth, but it's very important for the vital and non-vital teeth, and we know very clearly that it's a bigger problem, bigger issue, if we have a non-vital teeth discoloration, because it's not easy bleachable. There are also some contraindications, and I have to mention about that. The C, composite versus ceramics. So everybody is talking about composite today, and I'm in love with composite. However, in some cases, with the discolorations, we have to balance between composite and ceramics, and I would like to talk about indications for porcelain indirect restorations. D, like decays or structural deficiencies, and we'll try to understand the structural limitations of the treatment, which is very important, especially for endo-treated teeth, when we crown them or when we have when we are in balance with losing ferrule. F, like function, to understand the functional aspect of the plant restorations. This is, I would like to say, it's something new in my clinical practice, because being an endodontist, when I was focused on endo only, I didn't have the idea about the function. I didn't have an idea about planning the restorations of the full mouth restorations. And today I moved a little bit to the prosthetic world and to restorative world, and I fulfilled the John Coy's curriculum in United States, in Seattle, being able to understand better the function, and especially functional problems are very important for endo-treated teeth. So let's start. We go for a little bit of introduction. The most important reason of lost treated teeth is their unsuccessful restorations. It's curious, very curious, because in the past I thought it's a bad endodontics. But in how many cases we make a wonderful endo, and although we made a beautiful endo with long and root canal filling getting to the apex, but unfortunately they are not working well if we don't have a well sealed restorations from the coronal side. So, resumming the endo-treated teeth, we can say they have decreased mechanical resistance because of tooth structure loss, because of physical mechanical changes like the hydration of the dentin, changes of the collagen, decreased mechanical properties due to endo-irrigants and medications, deteriorations in aesthetics. So, summarizing, please remember about these 4 things. So it's no doubt that endo-treated teeth are a bit weaker and about more problematic, a little bit more problematic than vital teeth. So now talking about aesthetics like A, and B like bleaching. Do we need crowns in endo anteriors? I would go back to the very well-known citation from the past, but maybe to the younger colleagues it's better to emphasize even better that coronal coverage didn't significantly improve the success of endo-treated anterior teeth. So Once more, summarizing and making it simple, if we have endotreated anteriors, please, in most of the cases, we don't have to crown them. We can crown them because of some functional reasons, or we can crown them because of aesthetic reasons and because our adhesive restorations like the veneer or composites doesn't supply very good adhesion for the future. So in this case we can think about mechanical resistance and crowns, but please, in most of the cases we can forget about anterior crowns today. So of course this is very bad preparation, and this is a huge preparation. Please forget about this kind of preparation. But sometimes removing the old crowns, we see the cases like this. And we know from the paper of Edelhoff and Sorensen about tooth structure removal associated with various preparation design for anterior teeth that preparing for the veneers, we are losing around 3 to 30% of the tooth structure. However, when we prepare for the crowns, we lose so much, sometimes 60, 70% of the tooth structure. So please avoid tooth preparation for the crown if it's possible. So in different countries, we have different habits. In the United States, people are trying to have the most bleached teeth possible. In Europe, a little bit different ideas about the tooth aesthetics. However, it's changing towards the American ideas. In some countries, like in the middle, you can see the pictures from Madagascar, Salvador, and in some countries, the aesthetics could be a little bit different than we can imagine. So aesthetics is different in every country. In our part of Europe, in Eastern Europe, because of a little bit strange endodontics from the past, we have a lot of discolored teeth, discolored because of root canal treatment, and discolored because of, let's say, not total removal of the pulp structure from the pulp chamber, or the endodontic sealer which was discolorating the tooth structure. So we can have a lot of problems today with the aesthetics because of this endodontics from the past. So again, in anteriors, please avoid crown preparation if possible. And if we have discolorations, we can use walking bleach technique. However, this is a technique for really very careful dentists, because uncareful removal of the tooth structure can really compromise the tooth structure, and it can break. The tooth can fracture in the end, or we can lose so much tooth structure that it will be more compromised, and in the future will cause problems for us. So in the past we were using sodium perborate with 3% hydrogen peroxide. Today I know that sodium perborate is a little bit problematic in the European community. However, in outside European community, in the United States, as I know, it's still possible to use, and it's quite safe substance to bleach the teeth endodontically. Please be careful with hydrogen peroxide. If you use it internally, it can be maximum 3% of hydrogen peroxide. However, in many cases you can use sodium perborate with distillate water. In European Union countries, if there are some law issues concerning the using of sodium perborate, we can, for example, use 10% opalescence and place it inside the pulp chamber for a 3-5 days, and then change it periodically week by week. So 5 days bleaching, then exchange, 5 days bleaching, exchange, and another 5 days bleaching exchange, and that should work to bleach the tooth internally. Let's see the case of 24 years old Sylvia. It's a very beautiful case because discoloration was really very severe. But although the coloration was very severe and the patient wanted to place the crowns, it was many years ago when we were doing that, we tried from retreating the tooth. So we retreated the tooth, made the retreatment, and then bleached it internally, and we were able to achieve very nice result. And you can see that you have to use the barrier. The barrier, it is very important issue. So when we're using the barrier, we are protecting the canal from diffusion of the bleaching agent, which can be a little bit dangerous for dentinal tubules, periodontal ligaments, and the bone environment. So bleaching agent was placed, 3 times exchanged, and at the end we lined the internal vestibular wall of the tooth with the very light value of the composite, and then placed the fiber post, and a little bit over bleaching was achieved, but at the end we can see very nice result. And at this stage we can stop, we can finish the case, or in a few years, if the patient is not completely satisfied, we are able to place the porcelain veneers. And you can see, although we placed porcelain veneers many years ago, they were placed not subgingivally. In this case, we were able to have very healthy periodontium and very good conditions for the hygiene to proceed the hygiene work for the future. So before, after bleaching, and porcelain veneers on the right side, and you can see the smile of the patient. And when we elevate a little bit the gum, we can see that the transition between the tooth structure and the porcelain veneer is very smooth and doesn't disturb the periodontal tissues. So we have to remember about also contraindications to internal bleaching. It's important because we can bleach, but please, if you bleach, bleach it very carefully. So very small amount of sound dental tissue, cracks caused by trauma in the past, patients under 19 years old, discolorations caused by metals, and teeth restored by metal or fiber posts, and clinical situations with risk of perforations or fracture due to bleaching procedures. These are the contraindications for the internal bleaching. So you can bleach, but please be careful when you bleach.
There is always a question about recurrence of discolorations, because a lot of colleagues are saying that yes, we can bleach the teeth, it's not a problem, but the real problem is the reoccurrence of the discoloration. So it is the truth, and therefore this is the method borrowed from Dr. Walter Devoto from Sestri Levante in Italy, and I use it since many years. I think it helps. So we use a kind of reservoir on the tooth which was discolored and which was bleached endodontically, and in the reservoir from the buccal and lingual side you can place the bleaching gel, and using 2 windows on the neighborhood teeth you're able to remove the excess. So you can use, for example, 6% hydrogen peroxide in Novon technology produced by Optident, and you can use it for 7 nights every 6 months. So resumming the bleaching, we have to understand some kind of levels, importance and possibilities that we can make during our treatment. First is A, which is the most important, retreatment, rinsing by sodium hypochlorite, then proper cleaning of the pulp chamber, internal sealing with luminous composite. This is that everybody can do without any problem. Now, the bleaching by itself, it's a little bit more complicated because you need microscope and you need some magnification procedures, and maintaining the bleaching effect also demands some time as well. And the C, which is even level up, sometimes although you bleach the endo-treated teeth, you need to cover the surface at the end with porcelain or composite. The covering is easier now because the hiding very discolored tooth is very difficult, but hiding a little bit lightened discoloration, it's a little bit easier. This is the same like with the restaurants. You can have a basic restaurant, you can have a traditional restaurant, and you can have a gourmet restaurant, because we can compare the restaurants to our dental practice. So I would say for every kind of practice from all the continents, there is a place for bleaching. Just we have to choose the right procedure, because in some practices we don't use the microscopes. So maybe removal of the tissues from the pulp chamber, removing the sealings, removing the old materials could be a little bit risky without magnifications. So we have to remember about our limitations concerning the equipment that we having in our dental practice. More detailed article, please, I will recommend you. Please read my article. You find it in the internet, Non-Vital Tooth Bleaching, a case discussion for the clinical practice, written in Compendium Continuum Dental Education in USA. And also at the Stile Italiano website, you can download for free the article about the bleaching, very detailed procedures, step by step. How to prevent cervical resorption, because cervical resorption is an issue, and we need to understand that sometimes it's important to avoid thinning down of tooth cervical part. Also, barrier placement with glass ionomer or phosphate cement is very, very important. In young patients under 25, please replace hydrogen peroxide with distillate water. It's really important not to use high percentage of hydrogen peroxide or not at all in young patients. And place calcium hydroxide into the pulp chamber for 14 days following bleaching. It's also a very important thing. Regular X-ray follow-ups are also recommended. Always coming back story with the posts. It is important. Is there sufficient tooth structure do we need to place a post or not? So I would say today in contemporary dentistry, nowadays, we don't need to place fiber posts in all cases. For example, in posteriors, we don't place posts almost in any cases. But in the premolars and anteriors, sometimes we have to place the post, especially when the structure of the tooth is damaged in more than 50% in coronal part. We were able to publish recently the article published in International Endodontic Journal with the group from WIC University in Barcelona and with a friend from Italy. We were able to classify the endo-treated teeth for different classes of the restoration. And the class 1, where we have a lot of tooth structure, no posts, only composite core buildup. In class 1, where the percentage of the tooth damage was bigger than 50% in the anterior and premolars, we would place a fiber post while still in the posteriors we can avoid fiber post. In class 2, we need a pre-restorative procedures in order to place the fiber post. I'm talking about the situation with the limited ferrule. There, orthodontic extrusion or perioclown lengthening is a really good solution. In some cases, in class 3, we still can place a gold cast post or just cast post. This is the situation especially very popular in USA, where the posts are really, metallic posts are really used very much. We would recommend this kind of treatment in cases with a very severely damaged teeth, but where no ortho or perio procedures can be done. And these are kind of compromised situations. Also, class 4, where the extractions are needed, this is a severely damaged teeth, where the restoration cannot be planned due to very bad prediction. Again, beautiful Krakow, where I'm spending a day today. We have now a sun, fortunately. However, in November, it's a difficult time to have a sun, and in December it's even worse. However, the city is beautiful because the Christmas market is coming soon. Composite versus ceramics. This is always coming back story because we have a lot of ceramic lovers and a lot of composite lovers. But I would say there is a place for both solutions, and I will try to divide nice solutions for myself, at least for composite, and nice solutions for the ceramic. This is a case where we have asymmetrically positioned discolored tooth. And particularly in this case, I'm able to bleach it internally. So if it's possible, I try to bleach it. And in the effect is not perfect, but I was able to bleach it at least a little bit. I'm able to cover the discoloration with the composite veneer and mimic the white spots on the neighborhood tooth. And this is the situation before on the left side and the situation on the right side after the treatment. And we were very satisfied, first because we bleached, and second because we were able to place the right ratio of dentin and the right ratio of enamel, which is really crucial to achieve good color. And this is my son with his girlfriend, first girlfriend in Thailand, and he was very happy with her and she was very happy with him. But one day he discovered the Sprite and forgot about girlfriend, and therefore she was very upset and she said, please, Maciek, stop, this is the last day we made, we have to break, you have to find another girlfriend. So sometimes girlfriends are like a composite material, they're wonderful, but we have to take care about them and about composite. So we need maintenance of the composite. And I would say the good oral hygiene, the regular hygienization, like professional hygiene every 6 months, non-abrasive toothpaste. So we have to recommend to the patient right toothbrush, right toothpaste. It's quite important. Avoidance of the smoking and diet that cause extrinsic staining. So maybe red wine is not really good situation to drink it every day. And regular professional repolishing, if needed, with aluminum oxide should be the maintenance of choice. And of course, if the patient is properly chosen, we can achieve amazing results with the composite veneers. On the other hand, we have teeth which are not bleachable. Of course, we can try to bleach everything, but maybe there is no need to bleach everything. Look, this case, this is the male patient in the age of 35 and tooth 1-1 endotreated. What is important clinical parameter? Severe discoloration, no bleachable, and asymmetrically positioned tooth. Why it's not bleachable for us? For us, the situations not bleachable are, for example, the situations with the posts. Because I can remove the posts in order to retreat endodontically the tooth, but I don't like to remove the posts just to bleach the tooth, because I don't want to compromise the tooth structure. I don't want to remove a lot of tooth structure to place there a bleaching agent, to bleach it, but to risk the fracture or to risk the cervical resorption due to diffusion of the bleaching agent to the bone. It's a risky story. So in this case, we decided not to bleach, and we decided that it would be a good solution to make a porcelain veneer. But to make one porcelain veneers, it's a again risky story, because my technician would kill me for single veneer restoration. Can I do that? Of course I can do that, but sometimes I have to bring the patient 10 times to the dental technician and all the time improve the ceramics. But why not, for example, to make two ceramic veneers, so-called additive ceramic veneers, with the additional volume of the ceramic from outside, from the buccal vestibular side. So if we are able to increase the size of the veneer, maybe elongate if needed, we can check it, but maybe with a little bit bigger volume buccally, we will be able not to prepare too much to the tooth structure. So we will be able to save the enamel and not go to the dentin. And in this case, we'll have longer adhesion for the veneer restoration. So it's a very important and interesting solution. Instead of one veneer, make two veneers, additive veneers with smaller preparation, and in this case we have less risk of mismatching the color, and we have a less risk of removal complete enamel. So paradoxically, doing two veneers, we are less invasive than doing one veneer in this case. Interesting story. So let's look in the case. We check the patient, we make mock-up, and due to mock-up procedure, we will be able to check if the patient likes the situation or he doesn't like to continue the treatment. So in this case, please, we are able to check the situation, and it's possible to make the silicone index from the wax-up. Wax-up is very important. Please, if possible, make a wax-up. If not, make a mock-up. And for the mock-up, try to understand the situation of your patient, if he is able to have the right phonetics, if he's satisfied with the new smile. If yes, we are able to continue the treatment, and we can start removing the tooth structure, but through the mock-up. So the minimal invasive preparation can be always done through the mock-up, because it's less risk to touch the dentin and to remove complete the enamel. Sometimes we change the inclination of the drill. It's very important to have a 3D preparation. So different angulation in the cervical part, different in the middle part, and different in the incisal part, and also different under the contact point, just to have nice transition in this risky area below the contact area. At the end, it's very important to polish and controlling with the silicone index, then placing the cords. After first cord, the final preparation, final polishing, and the impression with the polyvinyl siloxane impression paste. Okay, and now we are able, after a few days, to cement the restorations, removal of the temporary veneers. Sometimes we need a scalpel. Checking the emergence profile. Checking the approximal adjustment. And now checking the color of the glycerin gel. At the end, removal of the glycerin gel, looking at the mirror of the patient, and finally, when we have acceptance of the patient, we can place the rubber dam placing with the brinker clamps, rubber dam inversion, it's important. We are able to sandblast, then to etch, place the adhesive, polymerize at the end, and we'll be happy to cement the veneers parallelly on both incisors. In this way, we will be not able to mismatch the location of each of the veneer. And now the veneers are placed with the light cure composite. At the end, the composite removed, glycerin gel is placed, and final polymerization can be done. And with the scalpel number 12, we can remove the overhangs, and then at the end with the, for example, some instruments, it's possible to remove the overhangs, and with the polishing caps to polish the transition between ceramics and the tooth structure. And this is the final situation from the buccal and from the palatal side. And the patient is happy about the color matching because it's really nice. And please remember, we had a very difficult situation at the beginning. So this is the final smile of the patient. And this is the situation before and after the treatment. Before and after. And we can see that the situation, that the treatment that we thought could be invasive appeared much less invasive than we thought. Before and after, and very nice result. So, summarizing the indications for direct composites versus indirect ceramics, we can say about several parameters. Please, look, the age is an important parameter because we would like to place maybe composites in young patients and not necessarily ceramic in the young patients. Then intensity of the discoloration is important because it's very difficult to cover the severe discoloration in the case of composites, when in case of ceramics it's possible if the ceramist is able to mask discoloration. The teeth position is very important as well. As for the ceramics, I would prefer to have two symmetrical veneers at least, while doing a direct composite is much easier in the case of single restoration. Number of restorations matters because, of course, it is possible to make even 10 composite veneers, but maybe in this case would be a little bit better to use the ceramist in this case. And also lower and upper arch, I would say we make normally in our practice composite restorations in both upper and lower jaw, and the ceramic veneers usually are a good indication for the upper teeth. Why not for the lower? For the lower, it's not a perfect indication because sometimes we close the functional envelope. So for functional reasons, and second, the teeth are very small and it's very easy to lose the enamel and go into the dentin. Then also durability and the patient's economy matters. Ceramics are much more expensive for the patients, and composites are a little bit, not a little bit, they are much more cheaper. Okay, decays or structural deficiencies like D. It's important to understand the ferrule, and it's important to understand that speaking about ferrule, we need at least 2 millimeters from the buccal and palatal side to think about the predictability of the tooth structure or the crown in the future. So absence of the ferrule matters, and in this case, I was telling before, we can do or ortho crown lengthening or surgical crown lengthening, and then regaining the ferrule, we can speak again about the fiber post reinforcement. So one of my colleagues from my office, she did a PhD, Anna Hille. She did a PhD about the algorithm predicting the prosthodontic success after ortho extrusion. It's important to see where B is root length at present and A is crown length after ortho and C is subgingival cavity. So using this kind of algorithm you have on the left lower part of the screen, it's possible to predict the future crown, future restoration and its prediction in the oral environment. Please, this is my office and the team of the doctors that is working with me, and I have a pleasure to be with them. Some of them are doing the PhD and some of them are specialists in a different field of dentistry. Coming back to the orthocrown lengthening, look this algorithm which Anna evaluated. For example, in this case, this is a kind of dramatic situation. The B is 10 millimeter and A is 9 millimeter. So prediction of the crown is 9 millimeter, root length is 10 millimeter, but we have 1.5 millimeter of the subgingival cavity, and then when we will count it, we have 1.38. And remember that more than 1, it's unpredictable prognosis. And this is 138, so it's 38 more than 1, so the prognosis is very bad. So please don't treat this kind of tooth. Maybe it will be better to extract it and think about implant in this case. While, for example, in this kind of situation, when we have a very long tooth, although, because there is a broken instrument there, and the 9 millimeter predicted crown length and 2 millimeter subgingival restoration, but the algorithm says it's 0.81, so it means the prediction is pretty good and the favorable prognosis. So if you see this case of the patient, please, broken tooth subgingivally, if we are able to remove the instrument, and we were able to do that, and we were able to place the rubber dam with some kind of periodontal flaps, let's say, placed in the same time the fiber post, and then we were able with orthocrown lengthening to make crown lengthening and to achieve a nice ferrule, and this will be with a temporary crown, and the final crown half a year later will be a quite nice prediction of this tooth. And indeed, this patient is functioning more than 8 years treated in my practice. Should we remove the old posts? Of course, the old posts are a risk. This is a risk, and we know about that. When I was a young endodontist, I was trying to remove a lot of posts because I thought I can make better endodontics. But then I was amazed with the new microscope that I am working since '99. But today I'm trying to evaluate risk and benefits from the treatment, and this is really important sometimes to avoid it. For example, in this case, instead of removal of the post and placing fiber post, which is probably more aesthetic, and instead of bleaching this tooth, I think we can remove it. We can evaluate the structure, and with no need of endo, we can just sandblast and roughen a little bit the surface of the metal and cover it with the special opaque material from the composite. So the composite material works very well in this for masking. And then place the temporary crown, seal it, and then make, I don't know, a few weeks later the impression, and we are able to have one veneer and one crown, because we try to make parallel ceramic restorations, and at the end we can achieve quite nice results, cementing the veneer under the rubber dam, and then without rubber dam we can cement the ceramic material, and we have a nice result doing one lithium disilicate veneer and one lithium disilicate crown. But please don't remove the post if you don't need it. I mention sometimes important sentences for me of my mentors. Walter is my great friend. He's one of my mentors. I asked him one time, what is your biggest limit? He said, my biggest limit is I don't see the reality, I see too much ahead. So sometimes he's giving me some ideas from the future of dentistry, and we can discuss it together in our scientific group, Stile Italiano. 13 years ago we had a patient. The patient came after the midnight call to me, and she said, please, I have a problem with my teeth, because I was coming back from the party and my teeth were broken because I fall down off the stairs, and I'm really in a trouble. She was crying, and I came back from the mountains down to Krakow, a few hundred kilometers away, and I came in the morning and I told her, please, could you collect your pieces of the tooth that you are able to collect, and we'll see what we can do. When I saw her, I was completely sure we'll lose the tooth and we have to place the implant. So I already called my implantologist and said, listen, we have a patient, she's in a shock now, and at this moment we'll not talk about implant to her, but we'll talk about implant later, but prepare for this case. But meanwhile, I did some periodontal crown lengthening, I did some endodontic treatment, and I cemented these pieces of the ceramics like a good ceramist, which is placing the plates of ceramic in the bathroom. I was trying to suit everything together. And surprisingly, she was doing quite well, not only for a while, but for a few years. 8 years later, we have a black triangle, that's true, but the state of the restorations and the re-cementation of the tooth fragment is really quite nice. This is the 8 years follow-up, and this is the 12 years follow-up, and she came and she said, listen, Dr. Maciek, please, for 12 years we have these teeth which were supposed that I'm losing them. I know I have to be careful with them, but now I'm passing certain age, 40 years old, and I would like to have something more special. I would like to have a nice restoration. Could you propose me something? And I thought, it's a big risk. These teeth are big risk anyway, but maybe to reinforce them with the very thin veneers, composites or ceramics, I don't know. We did a mock-up, and when she left mock-up, she said, really, I can smile very well, I can close my black triangle, and we decided to make the mock-up,
and prepare the teeth for the minimal invasive ceramic veneers. In this way, we were able to change a little the shape. Of course, we were evaluating the function. The function was okay. And through the mock-up, we start the preparation of the teeth. We use the pencil just to understand the depth of the preparation. And step by step, we go closer and closer to the cervical part of the tooth and to the gums. We use very often the metal strip with the diamond just to be sure that proximal part of the preparation is very well visible. Sometimes pencil just to be sure where I touch the tooth with the drill. Sometimes changing the angulation, going under the contact point, because looking from the side, it's always risky that in the future this part will be visible for the patient and not nice for the aesthetics. So we want to cover this part of proximal surface with the ceramics. And then the polishing with the polishing cap. At the end, the veneer, the cords, retraction cords, and impressions. And the next appointment, already we are preparing for the cementation. We check the color with the glycerin gel, place the clamps of the rubber dam, etching, placing the adhesive, thinning the adhesive, then polymerizing, and with the heated composite in this case. Of course, we can use different solutions, we can use cement, we can use flowable composite, but the most important, I would like to have a light cure one, because in this way I can have a lot of time to remove the excess. And at the end, to polymerize it well, remove the polymerized excess, polish. And this is the palatal side, and this is the vestibular smile. Very nice effect. I'm very happy for this patient, and I'm very happy for this work. Before and after, we can see black and white. Also, after 13 years after the terrible fracture, and the patient with a happy smile. This is what we can do for our patients, because we are all together passionates of dentistry, me and you who are watching this lecture today. So before and after, and talking about passionates to the dentistry, I would like to mention the free age of my another friend and good mentor, Francesco Mangani. And what means free age? Means hands, because we are working with hands, because we are dentists, and we can train the hands all the time on the hands-on courses and everyday dentistry. But we have to make the plan, because without the plan we don't have the proper treatment. So we have a head, which is the second age. But we can have hands, we can have head, but it's nothing without our heart. And the heart is a passion, and we need passion for every day dentistry. So being a passionate, it's a very important story for us. And this is the sentence borrowed from Francesco Mangani, and I'm happy to give citation of one of my masters, one of my mentors. F-like function, please. We go into F, and it's very important because in the past I was thinking about endo, I was thinking about restoration, I was thinking about fiber post, I was thinking about adhesion, but I didn't think about the function.
And it's very important thing. If you look at this movie reminds me two dentists. Let's say two male dentists. And there are two coasts like a dentist, because we are discussing sometimes Mission Impossible. Or we are discussing, should we make these veneers on this patient or not make? But we don't consider the overall function. We don't consider complex treatment planning, and we are eaten by the case, unfortunately. But half a year later, we are discussing similar case, and we forget about the mistake and failure done few weeks or few months ago. So I would like to show you the clinical case of 45 years old female patient with the chipping of the porcelain crowns performed many years before, because in this case we had closed functional envelope. We didn't have any space between upper and lower teeth, but we performed the crowns and they chipped. They looked relatively well a few years ago, although we had some gum recessions, but today they chipped because they didn't have any space while patient was talking, smiling, eating, chewing. There was no space, no right space, no right functional envelope. So the functional envelope was restricted, and we needed to understand if we are able to open the bite, how we are able to open the bite, and what is the procedure. So we used the COIS deprogrammer for 4 weeks just to find the right central relation. And why we need the CR? We need a CR to plan the case, to plan where are the joints, to start the right planning of the occlusal surface, to start the right planning of the aesthetic. So it's very important to have a 0 point, to have a starting point. And for us, a starting point, it's a right CR position or around CR position. So we use so-called John Coy's deprogrammer because it was found by John Coy's, one of my other mentor that I'm happy to mention today. And then we registered the CR and we made the functional wax up just to understand how much we need to increase the bite to have the right aesthetics. So the aesthetics, the length of the central incisor were already established before with the previous crowns because the patient was happy with the length of the previous crowns. So we were sure about the length and the aesthetics we want to do. And now the patient was limited with the time, and we thought we have relatively good condition of the tooth hard tissue. So we will use the transparent index just to remember the surface of the functional wax-up and to transfer the surface of the functional wax-up to the teeth surface with the silicone index. So with this method, which was described by Amanato and Ferraris, we can cut one by one the silicone index. The silicone index is done by the Memosil 2 impression paste. It's a transparent index, and we check if we have the right position. We need to have a stop point. Usually the equator of the tooth is a stop point, and in this way we are able to transfer the right surface to the tooth surface. Now we roughen the surface of the tooth. We can use drill, we can use sandblast, we use the etching, adhesive, and then placing the part of the dentin, and then we place the enamel surface. So in this case, please, we are able to achieve really nice result. Of course, it's not easy. We need exercise. We need to train. We need to train removal of the excess. It's a one risk. We have to be sure that tooth which not connect to each other, they will not bond to each other adhesively. So we need to use the strips to separate the teeth, and we need to sometimes make a holes in the silicon index in order to have excess went through the occlusal surface in order to remove it very easily. But we are able to have a quite nice surface at the end with the dentin layer and enamel layer. And afterwards, after the posteriors were done, because we are increasing the dimension only through the lower arch, we leave the upper arch like it was. There is no need for small elevation of the vertical dimension. There is sometimes no need to do that through the lower and upper arch. In this case, we decided to limit the restoration only to the lower arch, and now we can make the anteriors with the composite. We make the chamfer and the elongation of the chamfer, and now the silicon index is made from the laboratory hard silicon, properly cut. Now we are able to place the palatal surface, and then we are able to make proximal surface and then place the dentin inside and the enamel outside and a little bit of the characterization, and this is the end of the composite story in the lower jaw. At the end, we are able to finish the case with the lithium disilicate to upper central incisor crowns, and this is the end of the patient, the end of the story of the patient, dental story. The aesthetics is done. The two central incisors made by dental technician from Rome, Franco Ferretti, one of another mentor of mine. And the lower part of the screen, you can find a lot of authors which are using the composite in the vertical dimension elevation, or are using the minimal invasiveness treatment, minimal invasive treatment in this kind of treatment. So you can look and search for the literature. Also in my articles in the Stile Italiano page, you can download few cases which are very similar to this case of minimal invasive composite treatment, increasing the vertical dimension. The final smile of the patient. At the end, we are very happy to see this kind of smiles, especially if we can say that the function will save the aesthetics for many years. Very interesting sentence. It's coming from Japan. Who rides on the back of the tiger can never dismount. What does it mean? If you once will get to the back of the tiger, you don't want to get down, because or you will be eaten by the tiger, or you don't like to be down because you feel the power. And this is the same with the function. This is the same with CR. Once you will find the way how to establish the occlusion with the central relation, you will never decide not to use central relation in the future, because the central relation make it much easier to understand occlusion, to make the proper wax up, and to set new occlusion from the beginning to the end. So please don't forget that never. Resuming the functional cases, it's very important to start with the point A, planning of the aesthetics, with the right photos. Sometimes DSD, I think during our session you will have a Christian Coachman lecture, so you will find how to make the new tricks with the DSD. Remember about the aesthetic walks-up, which means sometimes you need only vestibular part of the walks-up just to understand the aesthetics, the upper lips, and to understand the smile of the patient. Then you can go to the point B, which means centric relation. The centric relation is a really key point, because when you have a centric relation, you can understand about the restricted envelope, or you can understand about functional dysfunction, about the dysfunctional problems of the patient. And in this case, you can understand what you can do with the patient if you go for the ortho treatment, or you go for the prosto treatment, or you increase the vertical dimension, or sometimes you remove the premature contacts, and that's it, and you balance the bilaterally the occlusion. So you can do that both with the Cois and with the Michigan to find the centric relation. Then the point number C, which is functional wax-up. It's very important to do functional wax-up, both in direct and indirect cases, to understand what we wanna do at the end. But in this case, we did the wax-up, we did the silicone index, and we transferred with the silicone index the occlusal surface, doing the direct composite restorations in one day. So we were able to increase the vertical dimension in one day, making happy patient coming back home very quickly. With this case, I would like to finish my today's lecture. I think I made 1 hour, or approximately 1 hour. You can join me on the Facebook with my name Maciej Zaro, or you can write to me an email if you have any question, or you can find me in my book Endoprosthodontics, which is already in English, French, Croatian, and soon in Chinese and in Russian. And if you next year around Krakow at the beginning of March, 10th of March 2011, I would like to invite you to Dental Spaghetti, wonderful congress that we are making in the center of beautiful Krakow. It was a pleasure to meet you today, and I'm happy to see you again in another online congresses or live. Thank you very much.